I would like to call upon Dr. Meenakshi Bhat. Madam is the clinical lead of genetics department at Indira Gandhi Institute of Child Health and professor and chair of Center of Human Genetics. Ma'am has been one of the persons who've brought treatments for rare diseases into India. She's been instrumental in that, so it's very nice to have her here and hear her today.
Thank you, Dr. Ramya, Dr. Ann Matthew, and the whole team that's sitting here, and especially the families. I would love to take that credit that you have said about getting rare diseases into India. I've just been a small part of this whole journey, and I'm really pleased to be part of the ongoing journey. And my role was to talk about how genetics affects spinal muscular atrophy. So, all of us are going to talk about overlapping topics, but I thought I'd go slowly through this because it's the parents that need to understand. Unlike heart and lungs and muscles, which families can see, gene is an imaginary topic, so you have to know how the genes within a body is the blueprint of how the person is going to have problems. So what we see in children that are born with very early, and this is the commonest form of neuromuscular presentation of SMA, is the infantile type, in which they present with severe hypotonia, low muscle tone. And this is a neuromuscular disorder which presents in an inherited form, what we call the autosomal recessive form, and I'll talk about that a little later. Among the rare diseases, it's not as rare as we think it is. We think that there must be a frequency, and these are Western frequencies of about 1 in 6 to 1 in 10,000 children are born with this condition. And sitting in the audience here are plenty of carriers who have been tested for it. But if we were sitting just in a film theater, in a marriage hall, 1 in every 50 people would be a carrier of this disease. So it's not that uncommon to have carriers of this condition. So whether you marry within families or without, from outside, the chance of 2 carriers meeting up and having a child with SMA is not that uncommon. Identifying it early, and there's been a lot of talk about whether we should have something like newborn screening. Now that there is a treatment available and multiple treatments, maybe this is the time when we revise our look at doing newborn screening and picking up things much earlier so that it is to the advantage of the child that is being treated in the future. So the frequency being high is why we need the sensitization of both families and doctors and every other medical health professional to know more about it. Now, Dr. Ramya had already said to you that the strings of genes, which we call chromosomes, has got a particular area on it, on chromosome 5, where the gene is located. Now, this is a very complicated, even for geneticists, this is difficult to understand, because on a particular part of this string of genes, there is a duplicated area within which resides this gene. So the key gene that we are looking at is what is marked out in maroon, the SMN1, and just next to it, very close to it, is what they call a backup gene, which is called SMN2. For the most part, SMN1 gene is what is doing all the work. It is the one that produces the protein which keeps our muscles intact. But in the backup protein, the SMN2, which looks very similar in structure, but if you can see the circle around 7 and 8 in the pink gene, what you are seeing is a small area which is different. The 7th unit of the gene usually is missing in the second copy. When it's missing, what it does is it produces less of the functional protein. Only about 10% of the normal protein is produced, and the remaining amount of protein that is produced is actually a non-functional protein. This is what normally happens in people who don't have SMA. Now, obviously, what is our problem in SMA? We have a missing SMN1 gene. So people thought that it is time to take advantage of the other gene and somehow make it work. And that is the principle of all our genetics. So if we look at how easy or how difficult it is to do that, The red part is the real gene that works. The green part is the backup gene, which is the SMN2. And what you want it to do is, as the steps of this gene converting itself into the SMN protein is happening, we need to act at a very early stage. And usually you act at the pre-RNA stage, which is step 2, to make any modifications that you want to do, and this is what your treatments are going to do. It alters it slightly at this stage so that the SMN2 gene actually works exactly and patterns itself exactly like the SMN1 gene. When this happens, it should produce the normal quantity of normal protein and therefore re-establish the normal function of muscle away from the damage that has already been done. So why is this SMN protein important? Because at all stages of the nerve cell looks a bit like a plant, a flower on the top, and then all the way down to the roots. At every point of it, from the body of the nerve cell to the main stem, which is the axon, to the neuromuscular junction, which comes to the roots, and this is where it attaches itself to the muscle. All these parts have got the SMN protein doing something important. And by the SMN protein not being there or not being there in sufficient quantity, these children have a lot of problems because slowly over a period of time, the muscle cells die out as a result of not having enough adequate signal from the nerve cell. So this is why it's so important to pick up things early and do the diagnosis of this early. Now, while we are doing all this, we have to remember that every child that is born with low muscle tone does not always have SMA. There's a whole host, this is just one slide of many diseases that could mimic the same findings. They are inherited in different ways. They may be inherited in autosomal recessive way. And this is why it's important for the first child in the family with muscle tone problems to be tested genetically to find the real reason. You can't give the real therapy unless you know what the answer is. And it's very important to do a broad-based genetic testing to find out what is happening. And when we talk about testing, the testings are at various levels. They're quite expensive when you're getting the initial assessment of your child done. Among all the other things that you're doing that is life-saving, whether it's assessing the lungs or the heart or the muscle function, when somebody asks you to do gene testing, the whole importance of doing it is, it's the structure of the gene and what is wrong with the gene that is going to help you identify the real treatment for your child. Because whether it is gene therapy or it is one of the medicines that is given alongside, all of them is dependent on how the gene functions and how to make the backup gene work. The ideal test that is done, and most of your children must have got this done, is an MLPA test. It identifies not only the SMN1, it identifies the SMN2, and it tells you how many number of backup copies that there are in that person. In patients that you do not have the second copy and you strongly suspect, it's better to do full sequencing so that you can find out not only the missing or the duplicated bits of the gene, you can also find out whether there is a spelling mistake at the level of the gene. So it is required that it is done in full control in all the individuals in whom you do. Now, whenever I speak of this, we talk about what are the copy numbers. If you look above at the yellow and green copy, we have a double copy of every gene because you get one from your mother and one from the father. So the first pair tells you what is normal. You have SMN1, 2 copies, SMN2, 2 copies. And this is usually the pattern in normal people who do not have neuromuscular problems. In people that have quite a severe form of it, the SMN2 remains fine, but copies of SMN1 are missing. This is what is the infantile form. Now, if you have any additional copies of SMN2 but missing SMN1, it determines the severity. You can have 3, 4, 5, up to 8 copies of SMN2. And if you have multiple copies of SMN2, you have a milder form. It may be type 2, type 3, type 4 with later onsets. And this has been described by Dr. Ramya and will be talked about later. So what happened as a principle of this? This was used to make medicine. The first medicine that came through was nusinersen. And this is what we call an antisense oligonucleotide. The SMN2 gene needed to be activated. The point at which it needed to be activated to make it a mimic of SMN1 gene was what was done by the medicine that was invented. And it was as recently as December 2016 that the first medicine got FDA approval. We are only 6 years or 7 years since then, and you're sitting in this audience where there are so many people treated with the next and the next generation of these medicines, and we are sitting in one city in one country. Isn't it creditable that we are here so recently onwards? So for people who have had one baby with this condition, every time they go on to have another child, whether it's a boy or a girl, there is a 1 in 4 chance of this happening again. Many times couples come to me and they have one pregnancy that has been tested and forget to do it again for the next pregnancy. Every pregnancy in that family requires to be tested. Every time there is a 1 in 4 or a 25% chance of this disease appearing. Identifying it in pregnancy is possible. It's possible in Bangalore. It's possible in other towns. What we usually do is when the mother is just around the 3rd month of pregnancy, from 11 weeks onwards, it is possible to do a key scan, which is called the antenatal NT scan. After the scan is done, depending on whether it's one baby or a twin pregnancy, it is possible to test the pregnancy by putting a needle into the side of the womb under ultrasound guidance. At that point, you do not actually touch the baby, but you take a sample from around the baby where the baby is getting attached through the placenta. This sample is the start point of doing the genetic test. You do a genetic test to find out whether the baby is affected or it's not affected. The results take 3 weeks, and by the time you reach 16 weeks, you have an answer. When you get a result, you get a result like this. They tell you the number of copies of SMN. Over here it says 0 and 0 for SMN1. In SMN2, it says 2 and 2 from the pattern that I showed you before. This is the severe infantile form, and you know that this child will be affected from literally after birth or within the first 3 months. If you have multiple copies of SMN2, you know that the child will have a higher chance of having their first symptom much later. You take decisions based on these tests when it is done because it is as sure a test as can be done. What has changed over time? We have had since last year the National Policy of Rare Diseases, which is a national blanket policy for the country to look at rare diseases. In theory, it is present. In practical terms, a lot needs to be done in future. There have been 8 centers that have been identified as centers of excellence, and we are one of them in Bangalore. So what needs to happen is registration of patients that are eligible for treatment, eligibility being determined by the neurology team and their support team on whether a patient will really benefit from having treatment. Once that is done, there is a web portal on which is available through the Family and Health Welfare group in the central government, where the patient details can be uploaded. For treatments that are as expensive as those required for SMA, you really require support not only from the government, but also from CSR. And there is an avenue to raise funds through this, and we are in the early days of trying to get this done. In an ideal world, if I'm speaking here, a couple of years from now, 5 years from now, I'm hoping that everybody would have achieved that therapy, whether you come from Gadag or from Bidar or from Bangalore Central or from any other remote village anywhere else. So this is the hope that we need to get through, and this wouldn't be possible if we were not walking and talking together. In the background, in this rare disease run, it says, "Together, let's go the distance." That is what we hope to do in the future. Thank you very much.